I'm grateful for the opportunity to introduce this next session, titled Quality End-of-Life Care in Long-Term Care and Hospice Settings. According to the Government of British Columbia, end-of-life care is supportive and compassionate care that focuses on comfort, quality of life, respect for personal healthcare treatment decisions, support for the family, and psychological, cultural, and spiritual concerns for dying people and their families. Unfortunately, to quote Dr. Harvey Choshnikov, in end of life, we do not have a vocal constituency. The dead are no longer here to speak, the dying often cannot speak, and the bereaved are often too overcome by their loss to speak. By 2036, it is estimated that 425,000 Canadians will die each year. Every year, more than 2 million Canadians will be affected by the death of a loved one. As our healthcare system and providers evolve to meet the demands of an aging population, it is critical to ensure that all Canadians receive quality care irrespective of their place of residence at end of life. This symposium will offer unique perspectives regarding the programs, practices, and principles that contribute to quality end-of-life care in long-term care and hospice settings. If we could please hold all questions until the end, as we have 5 panelists in this session, 2 who have chosen to sit in the audience. And I appreciate that. Now it is my great privilege to introduce our first panelist. Dr. Jennifer Bombush is an associate professor at the UBC School of Nursing. Please join me in welcoming Dr. Bombush.
So it is my great pleasure to be here today. I was really pleased to be invited. And I was reflecting on my presentation and what I was going to talk about today, and thinking about 20 years ago when I actually first started nursing, and I was a floor nurse in long-term care. And at that time, we might have 1 or 2 residents die in a month. If we had 3 or 4, everybody got really stressed out because it was really hard to be looking after dying people. Now, we had years to get to know these residents, and we had relationships with them and with their family members. Nowadays, you can have 3 or 4 residents die in a week. Sometimes people are only with you for a day or 2 before they pass away. So this is causing a great shift in long-term care and around how much and the quality of end-of-life care that people are providing in this setting. So that's sort of the background of my story for what I'm going to present now. I'm going to try not to be too repetitive of what you've already heard, but give you a little bit of background, and then talk about some research that I'm doing right now with families in long-term care and what they have talked about around a palliative approach in that setting. So I wanted to just bring this up because these are the causes of death in Canada. And I think it's really important to look at this list and realize that by and large, these are chronic diseases. So people are not dying all of a sudden. It is not a surprise that people are dying. And that even cancer is beginning to be thought of much more as a chronic disease as opposed to an end-of-life disease. And we see now that even Alzheimer's disease is increasingly recognized as a cause of death, whereas when I started working, we would never have had that as a cause of death. It would always be pneumonia or something else that had actually been the cause. So we need to consider the differing clinical courses of these different types of diseases. So this kind of gives you a picture of why do we need to shift to a palliative approach from palliative care. So if you look at cancer, you tend to have a pretty steady course and then have a drop in end-of-life care. And historically, this is where palliative care took place. In heart failure, and a part of my research program is actually with people at St. Paul's at the Heart Center, having minimally invasive cardiac procedures at the age of 85 and 90, we see sort of a bumping up and down. So you can get really sick, but then you can get better. Then you can get really sick again. But then you can go in and they can say, we've just invented this new heart valve procedure, and you're better again. And so where do you fit in conversations about what the end of life looks like if you're bumping around on this disease trajectory? And if you look at dementia decline, you sort of just have this little up and down, up and down, up and down, until at the end, things go quite slowly. So that is not typically how we think of as end of life or how we have planned our healthcare systems around end of life care. So again, this is a bit of review from yesterday, but historically we've had palliative care, which is a specialized area of practice that provides care for individuals with terminal illnesses, usually in the last 3 to 6 months of life. And what you need to understand is, historically, palliative care teams did not come into long-term care facilities. So they would be considered part of home and community care, but if we said, we need some help from the palliative care clinical nurse specialist here at my care facility, oftentimes the answer would be, well, no, you're a care facility. You don't need to have palliative care services in there. That's not what we're funded for. We know people are going to die there. You should be prepared for this. So palliative care was not something historically that was brought into long-term care, so people didn't actually get to see and learn about what that was. And then we have end-of-life care, and this is something that we can do particularly well in care facilities most of the time. And that's care in the final 2 to 3 days of life. So I got this lesson early on. The first night shift I ever worked, somebody passed away. The care aide who had decades of work experience came to me at 3 o'clock in the morning and she said, I think Mr. Smith is dead. And I said, is he dead or do you think he's dead? Because I've never seen a dead body before. Because I was 21 and this was my very first night shift. But what I learned over time was that care aides, when well supported, do end-of-life care really, really well. And everything I needed to know, I could learn from them about how to do that well. And everything I need to learn about the medication side of it, I learned from fellow registered nurses. So it's really a learn-on-the-job kind of a thing. And I was fortunate to work with fantastic people, but not everybody else has had that experience. So again, I think Kelly and others talked a lot about a palliative approach yesterday. So what are some of the key characteristics? So it's a transition from procedure-focused to palliative-oriented care. And you apply the principles of palliative care earlier in the illness trajectory. So we're not talking about just the last 3 to 6 months. But even if you don't have a chronic illness, this is a conversation that needs to start early. My husband loves to have them with me. He knows exactly what's happening to him, and he knows exactly what's happening to me. But it is important because things can be unexpected, and it's really hard to start these conversations at the end of life, when you're in your 80s and your 90s, because it's really uncomfortable. So the earlier you start, the easier it is, because it's further away. Focusing on alleviating suffering and improving quality of life. So my 98-year-old grandmother who lives in a care facility was recently sent to the emergency because she had acute pain. And it was great that she went there, and they wanted to admit her. They were very kind and wanted to admit her. And we said, no, she can go back to her facility and we'll find out what the prognosis is from within the facility. Because I also do some research about older adults in the hospital, and I know that my 98-year-old grandma wouldn't be with us anymore if we had said, oh yeah, a couple nights in the hospital are okay. So she went right back to her facility, and we found out everything was okay. But we didn't have her stay in the hospital when it wasn't necessary. Having intentional goals of care discussions. So I'm not sure if you had a lot of conversation about this yesterday, but this is sort of what I'm talking about. Like, where is this train going? Where do you want it to end? How do you want that to be? And having very intentional conversations. And a lot of times this can make people really afraid because they feel like care is being withdrawn. And so we don't want to be in a situation where we're saying we're withdrawing care. Rather, how do you see the situation unfolding for you? Because that changes over time. And then relational care. So it's really hard to have these conversations if you don't have a relationship with a person. So if people are coming into care facilities already at the very end of life in the last 2 or 3 days of life, this makes it incredibly hard. But when you have time, you can develop relationships and engage in more long-term planning. So this is sort of just a visual of what a palliative approach looks like. So rather than having that sort of distinct separation between very interventionist procedure and curative focused care, and then have palliative care where you're essentially withdrawing a lot of the interventional care. This is something that happens over time. And over time you decide what do you want to have and what don't you want to have. And it's an ongoing dialogue. It's not a one-time conversation. So the other thing is around where people die in British Columbia, because whenever I talk to people, they say to me, well, I'm never going to end up in a care facility. And I just smile to myself and I say, okay. You have done no planning, you haven't renovated your house, you don't know anything about community care, but you're not going to end up in a care facility. Okay, you know? We realize that when you get there, you probably have never thought you're going to end up there. But we need to start thinking about it. So when you look at it, 3/4 of people with dementia are going to die in a care facility. We don't know how to provide care well for people as their dementia progresses in the community, particularly if they end up having very challenging behaviors that can sometimes accompany some kinds of dementia. So typically, people with dementia are going to be dying in long-term care facilities. And the other thing you'll notice is that the older you get, the more likely you are to die in a facility. So these are things people need to consider as they're planning for the aging process. So now I'm going to talk just a little bit about the research that I'm doing right now. I do research about improving the inclusion of families in long-term care. And one of the studies I'm doing right now is called Inviting Dialogue on Experiences of Active Involvement in Long-Term Care. Isn't that nice? But we're inviting dialogue, and sometimes the dialogue is very interesting. And we're doing this at a couple of sites here in the Lower Mainland, and it's an ethnographic study, which means the research assistants and I go in and we spend time in the facilities. And we see what's happening and we learn about it and work with families around what they would like to see their role be in that setting. So that just describes a little bit about what the study is about. So far we've been at 2 sites. One is a health authority owned facility and one is a nonprofit. So the third type of site that you might find yourself in is a private for-profit. So it's important to understand the different types of facilities that exist, and that even if you are part of the public system and you're going to a public bed, you could end up at any of those 3 types of facilities because the health authorities contract beds at all of them. And because you're going to the first available appropriate bed, and oftentimes appropriate gets dropped from the conversation and you're going to the first available bed, you could really have very little choice in where you are going to end up. So we wanted to look at what this looks like across different kinds of ownership. So we spent some time in these facilities, and so far we've done 134 hours, because as researchers, even as qualitative researchers, we like to count things. And we've done 134 hours of just sort of hanging out, and then we've done 39 hours of really in-depth interviews with family members. So these are interviews that range between like an hour and 4 hours. And sometimes people really need time to talk. So we spend as much time with people as they need us to. So I'm going to just talk about some of the things that we've seen. And it's been interesting because we've done these really in-depth interviews, and this is one of the topics that people least choose to talk about. So when I went back to my research team at my research unit, I said, quick, I need data about end-of-life stuff. They're like, Jennifer, we don't have a lot. People don't want to talk about this. They'll talk to us for 4 hours, but they won't talk about this. But we did come up with some nuggets that I'm going to share with you that were quite interesting. So first of all is this shift in services into long-term care. So whenever acute care needs beds, you go to long-term care. And you shove as many people in as you can for as many empty beds as there are. In the community, if there's no space in palliative care and you're of a certain age, well, you're old and you're dying, so you can go to a care facility. So this is what one of the nurses said to us. She said, there were cases where people would be listed as a candidate for a palliative care ward, and palliative care wards, which the other panelists are going to talk about, are quite wonderful places. And so is hospice. But she said, but there's no bed available. So the next option is, okay, do you have money? That's always going to be a question. To go back into the community and basically purchase your services and have the kind of death that you really want to have? Well, no, if you don't, that's too bad. Then there's this residential care bed available, and we'll have the palliative care outreach team take over your case. So you get moved into a care facility, and the palliative care teams, now that some of those walls are coming down, may come and see you. That will depend. But mostly, when the resident is not capable of making their own informed decisions, it will be the family member to make it as a substitute decision maker. And sometimes they're not in the best state of mind to make any informed decisions either because of stress and emotional transitions that are happening. And usually, these are the people with non-cancer state. It's just a chronic illness. So this is why these conversations are so important before you end up there. And they're hard. And on New Year's Eve, this was a conversation my parents and I had again because they get to be related to me. And my sister is a social worker in long-term care, so we talk about this constantly. But it is really important because we have seen people in that crunch time. And it doesn't often end up being very good. So this is what one family member told us, and this was a friend, so family by choice. And she talked about the conversation she and her relative had had. And she said, I know I'm going to walk in one day and she'll go, who are you? So I'm not fooling myself by thinking, oh, it's going to be all nice and cushy and she can have family night and activities here and everything's fine. I know she's going to get worse. And with her physical health challenges, I ask, well, how is that all going to manifest? And how is that going to be regarding her end-of-life care? So that what we've been learning is that there are some gaps in knowledge around what does this actually look like when you get to that end point? Because it's not something, if you haven't experienced it personally or clinically, that a lot of people really have a picture of in their head. So she went on and said, she and I have had some pretty frank conversations. I said to her one day, I said, you haven't done much for me all my life. I want you to do this. Get your stuff in order. Get your documents in order. Tell me what you want, because I don't want to be guessing when the time comes. And she understood that. And she did that sort of stuff for me. I've got a pretty clear idea of how she wants her end-of-life care to be. So this was a family that took it upon themselves, and they did that family work, and we call that work in families, to have these really hard conversations and the importance of getting the documents in order. And I thought that was a great session right before this to talk about, what are the things that you need to think about? But then we have the other side of things where these aren't conversations that people have. And this often happens in long-term care facilities, that one of the first things we do in your admission assessment is say, what are your funeral plans? I cannot tell you how many people get upset with that. And you can probably tell at this point, I'm the kind of person, I don't say this to them, but in my head I'm thinking, this is the last train station for this railroad. Where do you think you're going after this? Because this is it. And I need to know who to call when you pass away, because you don't want to know what happens when we don't have a number to call. That's not really a conversation we want to have. You want to have this figured out. So if you haven't got your funeral plans figured out, and I horrified my mother a few years ago because it started happening where my parents' best friends have started to pass away, and the shock of the cost of a funeral of $30,000 when you're in that crunch time and you haven't made any plans. And I said to her, so unless you want your body donated to science, you need to make these plans. And within 2 days, they had purchased their funerals, and it is paid for, and it's done. And I don't say that because, I am not a good daughter, because I think I am, but I've just sat there with people at admission, and they're just like, I can't believe you asked me that. I'm like, well, really? This is it? Unless you have a preferred facility, I don't know. Anyways, so this is a family that has done a good job of getting their stuff together. Then we have this, and this is unfortunate, and this is not where you want to be. So a wife was talking to us, and she said, the staff, they caught up with me the other day. She's walking the hallway with her husband, who's the resident, and he was in his wheelchair. And the staff's just talking about this as if he's not there. And I'm sort of like, he's right there. Can you not see him? I don't want to talk about this in front of him. And she says, this has to be filled in. You have to do this so that as soon as he's died, the remains have to be out of here, and you have to have everything set up and give us permission to get the remains out of here. Now, this is in the hallway. The husband is not dying right now, and this is the conversation, because this staff member needs to get this part of the chart done. And the wife said, it was so blunt, I almost burst into tears. And the thing is, I wanted to say, do do you mind? Could we talk about this privately? Because like I say, there are things I don't know what is absorbed and what is not. Her husband had a progressive dementia. So I was so upset. I took the form, I took it home. I still haven't filled it in because I couldn't bear to look at it. And then she went to the care conference. And at the care conference, the staff was there. And she just threw that form down on the paper and said, I see that you have not done da-da-da-da-da form to address whatever, so what are your plans? Because this has to be ticked off during the care conference. And I said, I don't have any right now. As soon as I do, I'll let you know. And I've been avoiding her like the plague. I don't think this should be done in the middle either of a meeting or the middle of a hallway, which is where staff stopped me the first time. So you can see all those nice parts of a palliative approach, relational care, transitions, talking about how much intervention we're going to do. None of that has happened, and it's boiled down to a piece of paper in the chart. Because I will be the first to say, we don't necessarily do this well in long-term care. So what are the implications? Interpersonally, we need time and space for relational care. So it can't just be all about the forms or the time of admission. What do you want me to fill in here? Who do I call? There has to be more to it than that. And you have to be really considerate about the who, where, and when of the conversations, obviously. And acknowledge that there's a lot of grieving going on. And depending on the family, what we see is these issues that come up, they are long-standing. They didn't start at the moment they walked in the door. So there's work that needs to be done in this family, and it's not going to be helpful to say, get this form done. But at a systems level, we also really need to consider the resources. So how much education do we provide in care aid programs that are how many weeks long around end-of-life care, around a palliative approach, around having these kinds of conversations? What kind of staffing do we have? If a care aid has a 1 to 10 resident ratio and one of those people is dying, who's with that person when they're dying? That is one of the most heartbreaking things, is to have someone where nobody on staff has time to be with that person, and you all know that by the end of the shift, they will be gone. Having equipment and having space, having that place where someone can die, that is the kind of place where you would want to die. And so these are all things that need to be thought about as we support the growing number of deaths in this care setting. So that is my story so far. So I just want to acknowledge people I work with, and if anyone wants to get a hold of me, you can always email me at gero@nursing.ubc.ca. Thank you.
Hello. I just want a shout out to what we're talking about. Death and dying is a difficult topic, but there's a lot of laughter, and there's a really neat quote that says, it's okay to cry when someone is dying, but it's okay to laugh too. And it is, and you're doing a good job. I know it's a difficult topic. My name is Lindsay. I coordinate the palliative support services at the Ridge Meadows Hospice Society. So what that entails is the supports and programs to families in our community who are on the palliative program, but who are also at end of life for whatever reason. I also coordinate and mentor the volunteers who do that work in our hospice society, and I'll talk about hospice societies a bit. So it's just a real pleasure to be here today to share from a hospice society perspective how we can better companion people at end of life, and really no matter where they are. I'm speaking from a hospice society perspective, but in an audience of us today, we are family members, we may be physicians, we may be social workers, we may be friends of people who are at end of life. So I think as we go through this, even if you can take little pieces of how to companion those who are dying, it's a great takeaway. So the key pieces I'm going to share today, primarily looking at the tools that we use in hospice care to create those meaningful moments and interactions with our patients and families. And then how could we possibly use those tools in a long-term care setting in order to ensure that we're addressing that whole person care, those psychosocial needs of our residents in long-term care. So it was hard to narrow it down to the things that our volunteers do well, but the two concepts we're going to discuss is number one, presence. So being present for somebody as they're dying, and number two, the idea of companioning, how to be a companion for these people as well. So you may be familiar with hospice societies, maybe not. Basically, they are nonprofit organizations found in most communities that provide all the supports and programs to people on palliative programs and living at end of life. At the Ridge Meadows Hospice Society, our mission statement is pretty much the same as most hospice society mission statements. All of us adhere pretty closely to the BC Hospice Palliative Care guidelines. And for us in Maple Ridge, at the Ridge Meadows Hospice Society, it's to provide compassion, support, and care to people at their end-of-life journey, and then including through grief and bereavement in mourning, pretty much, give or take. Our services go wherever people are, and that's important to note, that a hospice society can support people wherever their home is. So number one, a long-term care home, a hospice residence, the home you've lived in for 30 years, in a hospital awaiting a transfer maybe somewhere else. That hospice society supports can come to people where they're at. So how that looks is specially trained volunteers who go through a lot of training in order to do this work. And our volunteers are the people who offer that emotional support to people as they're going through this journey. So not therapy, not counseling, but recognizing that death and dying is a natural part of life, and often we need that emotional support alongside of us. A hospice society plays a key role, hopefully, on their community's palliative team. And also, a hospice society, on that palliative team, if everybody has a role to play, be it the physician, the social worker, or pharmacist, whomever you are, spiritual care, a hospice society and our programs are there to focus on those psychosocial, emotional needs of people who are dying. So at our hospice society in the last year or two, we've really made it part of our strategic plan to raise some community awareness about our programs and supports, because we are that little known resource that I think, unless you're going through a life-limiting illness or know someone who does, it's not something you seek out or want to access. The BC Hospice Palliative Care Association too has announced in their last year that community education is going to be a big part of their focus, and it really, really is important, because nothing breaks your heart more in our hospice when people come and go, geez, I wish I would have known of these supports earlier. It's quite difficult. I've had a great chance to do a number of presentations at family councils lately. So family councils, those beautiful groups of husbands, wives, loved ones, children, of people who are living in long-term care settings, and just telling them about our resources and what's available to them. And it's been really well received. There's kind of that look at first, they're like, oh, what are we talking about? And then, as I finish, people are putting their hands up and people are really wanting to talk. People have a lot of questions, a lot of concerns, and a lot of personal questions on how can I best support my mom? What do I say to my dad? And it's really neat that we're having those conversations. So looking forward, as a hospice society, we're looking at how can we support our local long-term care facilities. There's all that beautiful, great research coming out of Lakehead University on quality palliative care in long-term care. And one of the foundations of that is really strengthening the collaboration with community groups. And we're on the cusp of that in our community, but really looking forward to how we can best support long-term care. So hospice volunteers do a lot of things really well, but one thing they do super well, I believe, is those little things, what I called this topic. The little things, and those are the things we remember. Those are the things that after you've been in the hospital, been in a care setting, you come home and you tell your loved ones, yeah, blah, 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 but there was this one nurse and she sat with me and she stayed with me extra and she brought me that ice cream. And people remember that. And those moments have a huge impact on how people move forward in their process after people have died and how they grieve. So in end-of-life care and palliative care, we are meeting people on a continuum of their end-of-life journey. And the time we are given to get to know people is often short, months, weeks, days. So we have to look at how are we going to maximize those interactions and moments so that we as a team are ensuring we're providing that quality end-of-life care that we say we want to do. Any member of a care team can use these little tips that we're going to be talking about. Any family member can use these little tips we're going to be talking about. So if we recognize that our time with our patients and residents is going to be time limited, how are we going to maximize those moments? One of the tools we use in hospice care a lot is the idea of presence. So being present for someone, there's a million definitions on presence, being present, mindfulness, but for the sake of end-of-life care, what I'm trying to convey is that it's just being with somebody in that moment. That when I am with this resident, I am trying to let go of everybody else and really focus on you in your moment. We are the tool we offer. We can talk theory, research, statistics with our families, prognoses, but ultimately, I will be the person sitting with you, and I have to choose how I'm going to be with you in that moment. A key to palliative care is making sure we're providing that time, that space, where people can express their fears, their hopes, their wishes, and then thus lead to those goals of care that are going to be so important at end of life. Family members are often hesitant. We're all part of some kind of family, and we don't want to hurt each other. We don't want to upset each other. We don't want to rock each other's boats. So we tend to not always disclose those big feelings to our families. And often it's those frontline workers, our care aides, our nurses, who are hearing those big feelings for the first time. And presence is about offering that time, that somebody can disclose that. It's about building relationships and about building trust. So presence is one of the tools we'll use. How can I be present? Simply starts with getting to know yourself. As care providers, we have to have a very, very, very strong self-awareness of our own beliefs, our values, our judgments, assumptions around death and dying. You have to have a very strong sense of your history, of your family of origin. Did people talk about dying? Did you get to go to funerals? Did we engage in those conversations? Because if we don't have that sense for ourselves, then we're going to often miss those opportunities to have those conversations. And those windows are small. And if we are not leading that, sometimes those opportunities don't come up again. The other piece is intention. So to be present, you have to plan for it. It's not magical. It doesn't just happen. I wish it did. But it does become part of your practice and how you work with people. You have to plan ahead. We always have a choice on how we're going to be with somebody in any given moment. We all feel strapped with time, with resources. But when I'm sitting there with someone, I always have a choice of how I'm going to be it for 1 minute, 2 minutes. And that's really empowering as frontline workers. Another great tip that we do in hospice a lot is establish, we call it just a reset in between patients. So I'm here with you in this moment fully, and when I leave that person, I let them go. We all have simple little rituals. I'll go to the bathroom and just wash my hands, honor my time with this person, so now I can be fully present now with you. So just another little idea from the hospice. The other piece is companioning. Dr. Alan Wolfelt has this whole beautiful philosophy of companioning, and we use this a lot in hospice training. It's just recognizing that this story is not about me. It is about this family at this time, and I'm going to come alongside of you on this journey for this part of your journey and then let you go, and that you are leading this story, that this is your story. We use a lot of words like acceptance, normalizing, recognizing that death is a natural part of life, and really trying to approach people from a place of non-judgment. It's about curiosity, learning from others, listening with your heart versus your head. It's a beautiful way to be with people at end of life. So how can we be better companions to people at end of life and their loved ones? One of the tools we use is empathic listening, empathetic listening, active listening, whatever you want to call it. You can take a million different courses in how to do it right. But again, for what our purpose is when people are speaking with us, disclosing, sharing, not just listening to that level one, what's being said to us, the words, but really having the intention to hear the feelings behind what's being spoken, and then work with that and respond to that. Think of a lovely lady, room 302, who you walk in and she goes, "Where's the doctor? He never comes, he never comes." The conversation can go two ways. We can go, "I know, the medical system, so frustrating, blah." And now it's going this way, on a rant. Fair enough. Sometimes there's time for rants. But if we just pause for a second and go, "Wow, lady, you sound really frustrated. You sound really concerned." She'll go, "Yeah, I've got this wound on my arm and I'm kind of scared that maybe it means something's spreading. I don't know. Pause, and now she tells you more about what she's really scared of. So we're going to try to respond to the feelings. Another tool we use is silence, and it's great. We're always concerned about what to say when somebody's dying, what not to say. I don't want to hurt somebody, I don't want to offend somebody. And often it's great to revert to just a pause and silence. So when people are talking and sharing, to just allow that space again for their story to keep coming. We don't have to say, "Oh yeah, okay, Just let them talk. Totally lost. So another piece of companioning is the non-judgment piece. In hospice, in long-term care, when somebody is dying, we're often meeting families at a time of real unsurpassed stress. People are not their best selves sometimes, and we are quick, I think, upon meeting people to jump to judgment and form opinions about people. We'll hear words like, "They're very anxious, they're very demanding, they're very this, they're very that." I've had my people die too, and I was very anxious, I was very demanding. And that's just the way we are. We take care of our families, and that ounce of compassion really does go a long way and becomes one of those little things that people remember. Okay, so we're going to meet people where they're at, follow their lead. We're going to open conversations with them. People want to talk about death and dying. Outcomes, I just put good for everybody. Good for the care providers, good for patients, good for families. We're going to have a better understanding of their values, their beliefs, their needs, their goals of care. As new things come up, we're going to have a better understanding of where that's coming from because we know a bit more about their family history. We've had a great relationship on now which to base our grief and bereavement follow-up because you can't have quality palliative care without having quality bereavement and grief follow-up for people. And it's good for us as a care team because it really takes care of us emotionally as well too. So hospice societies are in your community. I encourage you to check them out. If you need any more information or resources, the numbers are there. But thank you so much for listening.
All right, can everybody hear us okay? So my name is Shannon Freeman, and I'm an academic and an educator, and most importantly, I'm really driven to have what I do actually result in real-world change. And so today I'm here to talk to you with one of my partners that we do a lot of exciting, innovative things with. And what we really want to share is the how to partner. The how to partner with the university, the how to partner research with the community. So we titled it Bridging the Research Practice Gap through Partnership, the case of UNBC and the Prince George Hospice. So I wanted to kind of start off by saying, how many of you are part of a nonprofit or community organization or seniors in the community who are here? Okay, keep your hands up. Of you, how many of you are engaged in research activities? Okay, so a fair number of you still have your hands up, which is really great. And we hope by the end of our presentation, we'll equip those of you who put your hands down with the inspiration and some practical ideas on how to next time keep your hands up and partner with us to do innovative change. So the first thing we're going to do is give you a bit of an overview of the Prince George Hospice Society, and I think it'll really nicely complement our last speaker. There's some unique similarities and some differences and unique things that we have up in the north. Then we're going to talk about the importance of having interdisciplinary teamwork. And when we talk about teamwork, we are just two members of quite a large team of people that we work with in various capacities. Then we're going to highlight some of the research work that we do together, and then hopefully leave you with those really practical tips on how you too can get engaged in this kind of work that we do together. So
So I'd like to take the opportunity to talk about the Prince George Hospice Society, because that is my passion, and I have the great privilege of being the executive director there. So in 1987, the National Hospice Palliative Care Association was formed. This was the same year that a physician and a nurse in the Prince George Hospital saw a need to provide a palliative approach for the people dying in Prince George. The initial years saw the nurse training volunteers to be present and support people and their caregivers as they died at home. And to quote Elizabeth Kubler-Ross, those who have the strength and the love to sit with the dying patient in the silence that goes beyond words will know that this moment is neither frightening nor painful, but a peaceful cessation of the functioning of the body. The Prince George volunteers did just that. All support for Esther's Wages, which was the nurse at that time, were supported through the generosity of the community. That's one of the biggest challenges with our hospice societies, is the funding that's involved in order to maintain the work they do. But ahead of their time, the community of Prince George saw the need for a hospice house where people could get the care to die with dignity, surrounded by friends and family when dying at home was not an option. Luckily, the Prince George Rotary Society donated $25,000 to purchase a house. We're cheap in Prince George, not that cheap. We're not Vancouver prices, but we're not that bad. So the community built the first freestanding hospice house in British Columbia, where people could die in Prince George. How people could die in Prince George was now profoundly changed. Now, the new era for hospice saw the expansion of our services to include also grief and bereavement, education, and training. All of this because the community of Prince George saw the value and the support of the Hospice Society. So currently today we have a 10-bed hospice house where we provide end-of-life care. We are unique within our group that we also have a family suite, so families from out of town can stay and be present with people as they die. We have a kitchen that nourishes not only our guests, but the friends and families that come. We have a fitness room so caregivers could go and get the exercise and stress relief that they need, and a child's playroom. As we move into the future, we are committed to providing the hospice care that our community deserves. So just a look at our numbers, because I'm now with Shannon and she's now a data person. So 1,800 people received hospice care last year in the Prince George Hospice Society. We had over 8,852 volunteer hours. 8.6 days was the average length of stay of our guests. We saw 233 guests admitted into our hospice house. We have 214 active volunteers and 550 people supported in our grief programs. I'm going to just briefly explain our grief programs. We have several formal and informal programs. We have programs for adults and we have programs for children. One of our newest program, which we established, is Grief and Grub for Guys, which is a program for men to come and grieve together in fellowship, and we provide a meal and conversation for them. The Rainbows program is for children. It's a formal program that allows children to work through their grief, and their grief may be anything from even divorce or separations, loss of a pet. Children grieve very differently. And our Tea Time for the Soul, which is a drop-in program for people that can come in at any time and just have conversation.
And so I think one of the great similarities that our last speaker also mentioned is hospice is more than just inpatient dying in the hospice house. Hospice is very actively engaged in many initiatives in the community and see the need to really reach out to more than just the last 8.6 days of life. So I think one of the things that really Dawn and I both share a very common vision about is the need to have evidence and be evidence informed. To know that what you're doing is effective. To know that you're achieving the outcomes with the programs and the investments and the time to really seek and be able to measure that it's effective. And it's one of the biggest challenges in the whole field of palliative care. And one of the speakers mentioned the lack of literature in this area. And it is a huge challenge for us as a field to really move from grassroots, charitable, good-intentioned programs to evidence-informed things where we can show value, to advocate for more money, for more funding, for expansion of the programs that we feel in our hearts do so much good to the community. And so I think that that's where collaboration comes in, because the skills and the strengths of hospice nicely can pair with the strengths and skills of others in the community and within the university environment. Talk about our aim.
So our aim is to promote innovation, and we must be able to measure the outcomes and the success of our programs. I talked briefly about our Grief and Grub for Guys. It was a grassroots program that came out of a gap in our service delivery. What we're not able to do, because this was, again, something that grew out of a reaction, we're not sure on how effective it is, other than our assumed response and surveys from our thing. So what we were moving forward is into something that is much more evidence-based. We can no longer rely on simple satisfaction and happy stories. We need to be objective. We need to be accountable to our communities, especially in relation to the amount of money that they are giving to support us. We need to be defendable of our work.
Yeah, and I think that that is one of the biggest challenges. And I should also have a disclosure that I do sit on the board of hospice as well. And so I know the finances and the amount of time that the board and the volunteers spend to raise those funds. So to make sure that resources are being used effectively and get the biggest bang for our buck with them, becoming more evidence informed has become a priority. And we can't do this alone. That's the really important thing. To look at who has the strengths in the community or in other organizations that you can leverage to get this information and to get the evidence to know what you're doing is successful. So for us, and I said at the very beginning, doing work to improve the health, the well-being, the quality of life of vulnerable people in our community, and in our case, that is people in northern British Columbia, that's at the heart of what we do. We share that common interest. But you can see here, Prince George Hospice is here and the university is here. But we have a lot of collaborations with communities in northern BC, both in Prince George and outside of Prince George. We work closely and we advocate for further funding from the Northern Health Authority. That's where evidence is very useful. We can show outcomes. We can advocate for more money for further funding. We work closely with the Prince George Council of Seniors. So we know what the population of people in hospice that we're serving is now. What is it going to look like 10, 20 years from now? How are those cohorts changing and what are their needs? It's important to have them at the table for the conversations of where do we want our evidence and where should it come from. You'll see in our research, we work with a large panel of community experts from all aspects of end of life. And I think that's one thing that's really important in the partnership with hospice. I think throughout this conference, we've heard so many experts talk about their expert area. So we heard the legal area, we heard the medical area, we've heard, the person's own individual story, okay? But from hospice and from palliative care, having that whole person approach is where we build quite an integrated, interdisciplinary team to bring it all together. To bring all of that information into one place.
Yeah. And I'll add on to that. What it also does is it reduces the replication of service. We know that often other areas are working diligently on sometimes the same programs or addressing the same gaps that we see. So this way we've broken down the silos and we ensure that we're leveraging each other's, both their resources and their expertise, right again, centering it around our guests and our patients.
So now we're going to move on and talk about 3 different research initiatives that are led by hospice, partnered with the university and partnered with other key people in organizations in our community. And the first one is the gift of preparedness. And you can see from all of the information that we've learned in the past 2 days how much stuff is out there for people to wade through, for people to navigate through. What does it mean? What information do I need? Who do I get it from? Do I have to go and talk to 20 different people to get 20 different forms, 3 of which mean the same and 7 of which I have no idea about? So that's a real challenge. So our group initially was brought together by hospice to really promote end-of-life planning for all people aged 18 plus. And our goal of this big working group is to create a one-stop shop for people in the north so that they can go and access all of those different forms from all of those different people in one place, and where it's being presented at a level they can understand. Because even though some legal experts explain things 3, 4, 5 times, you still have no idea what are they talking about. Sometimes it feels like they're speaking a different language. And so the information needs to be presented in a user-friendly, easy-to-understand format. So this was led by Hospice, and it involves a large number of the people that we spent on the interdisciplinary team. Now, Donna, why don't you talk about how the partnership with the university brought a different shape to this project that was initially brought together by Hospice?
Yes, again, we often see the burden that happens when people are at end of life and not prepared. So we saw definitely there was a need to get people to start having the conversation. It's part of our advocacy with the BC Hospice Palliative Care, Advanced Care Directives, but we also know everything is much bigger than that. So it was very important to start getting this work out. So I had called people together, the experts, to gather information, to gather content, and then realized, it needs to be bigger than this. We need to find out what is the best practice, what are other people utilizing, why are we reinventing the wheel? And because of the relationship I had with Shannon, I said, would you like to participate in this and turn this into something that, first of all, again, is defendable and is current with best practice?
And so I think it's important to talk about developing a research question and what the difference is between just having an idea and really honing it into a research question.
Yeah, we often find we're looking for solutions to gaps in service. So we were looking at solutions, not the question, and that was sort of the big shift for me, was coming at it with much more of the research approach. What is the question that we're trying to answer? And that's where the group, I think, struggled at first, because we had quite a diverse group. We, again, had lawyers, funeral directors, physicians there, grief support workers. I think at times we said we were herding cats in order to get through the meetings. But definitely, once we got and formatted that question, it was the aha moment for everyone. It gave that focus.
So what we did was we started at, okay, well, what does end-of-life planning mean? Because we have a hypothesis that it means very different things to very different groups of people at different times in their lives. So let's find out, before we create this one-stop shop of information, let's find out what information different people in different groups want to know. So we held focus groups with lots of very diverse groups, ranging from students to caregivers and family members of persons in residential care, to frontline staff, to Rotary Club members, to 120 community dwelling older adults and their caregivers and loved ones, to really gather that information. And so with the partnership of a university, I was able to put that structure behind the question, to be able to say, okay, here's your question, here's how we can go about answering it. And that's exactly what we've done together, at the table together. And we've been able to map all these professional roles. We've got great diagrams of what are all the financial things, what are all the legal things, what are all the grief and bereavement things, what are all the community nursing needs, and things like that. So we were able to put together all of those professional roles in end-of-life planning to see what everybody says and look for the commonalities and the differences across those professional roles. We also did a thematic analysis of what do people really want to know, and it differed greatly between the university students who were worried about what their mother would find under their bed in their dorm room. I'm serious, the conversations were very unique. They were not even thinking about what is a will, why do I need it? They were thinking, what do I not want my parents to find? But it's important, and the other thing that we found is, how do you want the information delivered to you? How is the best way to do it? So some kind of themes that emerged was the importance to prioritize family wishes, the need for human connectedness. Decluttering was a very big one. Getting rid of stuff is difficult as you age. But is it a burden you want to leave a full house full of things that were meaningful to you and your children don't know what to do?
I think half the university students didn't want to see the stuff under their parents' beds either, so It works both ways.
So perhaps Yeah. A second really exciting initiative we have is one of the strengths of partnering with university is I get all of these grant opportunities that come across my email every day. So if there's a project and there's a call for funding, I can see it, but I might not have my own research project to fit into it. So the Community Action Initiative was giving out convening grants for their Cycle 8 funding for promoting mental health and wellness of older adults and their caregiver. So I forwarded the email. I said, hey, Donna, I think this is something really great. Would hospice be interested to talk about a project? So already having this relationship, and I know Donna, and she's interested in being evidence-informed, I can send her stuff, and she's like, hey, I've got this really great idea. You know, so we sat down and we made a plan of how we could fill a gap in the services that are available in the North in a new innovative way. And so we looked, we're creating a full application. We were successful in the convening grant to develop a virtual caregiver support program and a new in-person support program that's not currently available in the North. So when we did this, the partnership with the university, again, we brought in an environmental scan and a scoping review and all of these methods to really get the best evidence that we can to inform what we're doing to make sure that it's not repetitious and we're not reinventing the wheel and wasting our time and resources. And we're using them wisely. And so together, we were successful in the convening grant, which we drafted together. Which I think is also really important. Donna has a different way of writing than I do. So Donna drafted it, and then I provided some input. So the whole thing from conceiving of the question was done together. The whole process, we're equal partners as we move forward. What's your need? How do we do it? How do we marry those ideas, negotiate where we want to go together?
Yeah, I will quickly go back to that though. One of the things is working in my position, operationalizing everything is really key, but really hard to do without the people that were there to come and do the work for us. And what we found, again, when we were doing this specific work is we did the scoping review first, and there's, I will let you continue. Sorry, I'm ahead of myself. No, so anyway, the lack of real clear information that's out there, and I think that was one of the things that I really value about this partnership is actually getting the work documented, written up, whether it's to be published or not, but at least it will be out there to share with other organizations. Because really, we don't accredit our work as much as we should.
And where are we going? So we have gone through the literature. We've called a large number of hospices across the country to see what is currently being done, what's not being done. We've added all of that information together to really create our own proposal that we're hoping that will get funded, and if we move forward, then we'd have our own program. The last quick one I wanted to talk about was the digital storytelling. And for those of you who were here yesterday, you heard David Kaufman speak about that. One of the great things about tapping in and having an interdisciplinary team is we can tap into other networks. And so I've met David through other research that I've done, and I know Donna has done some stuff with video storytelling, so I'm like, hey, let's marry the groups together. You know, and so David has the strengths of digital storytelling. We have the interest of the hospice, and I can be the bridge between those groups. And so we've got some digital storytelling initiatives with David Kaufman and his group at SFU, which are so exciting and really fun to be part of. And hospice actually created their own digital story. So if at the end you write down their website, you can go see the digital story of hospice, which was something concrete that benefited hospice that they have to promote that. So it's important that these partners are very fluid. Our relationships, we expand and we include different members in our teams depending on what the question is and what we can offer. So before we run out of the time, the really important thing we want to share is what are the strategies for our successful partnerships? Because Donna and I, we see this as, we got another 20 years in this together. We do. This is the start of a really great relationship to move forward because there's always questions, And as a researcher from the university, I have great access to a wide toolbox to really help the community answer those. So Donna, want to start?
really a mutual respect for each other and the value that we bring to the work. I've held lots of senior leadership positions in healthcare. I'm an operational, I'm a get her done kind of girl. So that's what I bring forward. And Shannon brings that whole research academic slant to it, helping inform us of the questions. I respect the work that she does. I value it. I see it as important as she values that sort of get her done that I do.
Yeah, and that really is it forms the basis of our relationship, which is this trust. So we have this mutual respect that has led for trust. I trust in Donna that, the work that we're doing together, she's going to keep going. She's going to mobilize it into action. It's going to have value. And as a researcher, this is what we do research for, to impact real world change. It does me no good to do a study by myself, which I can write in 5 minutes, and it'll stick on a shelf somewhere that nobody will ever read. I want to do research that makes change. And so I trust in Jonna. We don't micromanage each other. We have a great relationship. We make a plan. We know who's doing what, and we move it forward.
I really don't want to do the scoping reviews.
Yeah.
Now I know what that is, though.
That's right. We reviewed, for that one, it was actually quite small. We only reviewed almost 1,000 articles to find 19. So if you can imagine sifting 1,000 journal articles, it's something that Donna definitely doesn't have time to do. And the last important one is transparency.
For hospice, the value we get out of this is we get funding opportunities, we get evidence-based and credibility with our work that we're doing. Shannon knows that's why I'm in it, why it's important to me. I also know that what's important to Shannon as far as manuscript publication, being able to go out and bring forward her work, because that's her world that she lives in. So we really have transparency about what each of the programs is bringing to us, both to the hospice as a whole, but to each of us as individuals.
And we have that conversation at the beginning. What are our metrics? What is our purpose? What is the value each of us will receive? And often our value that we receive and our metrics are very different. So as a new emerging scholar and a new person in my role as an assistant professor, manuscripts mean a lot. It means a lot to have that. But for Donna, to publish that scoping review, is that on your top 10 list of things to do?
Not so much.
No, but Donna will co-author that with me, because that's important that we've done this work together and that I respect the contributions that she's made. But first, I will give her all of the figures and all of the information in a way that she can use. So she not necessarily can use that manuscript scoping review I'm going to write that's 25 pages, but she can use the diagram. We can use that to form the basis for the conversation with our community partners. And so there has to be that transparency in what are you going to get, what am I going to get, and how are we going to give to each other with what we do. And I think those three things, if you can articulate them at the beginning of your relationship with your university partner, you're likely to be more successful than if you're not. And so, Donna, any last remarks you want to say about our great relationship of bridging that gap?
No, I think that we've been really fortunate with the Hospice Society to develop the relationships with the university. Really changes how we do our work, how we implement new programs. And again, when you're asking a community to support you with well over $1 million a year, you really want to make sure that there's thought and evidence and defendability in what you do.
And the last thing I wanted to say is don't be afraid to call up the researchers in the university and say, hey, I got a question. Do you want to help me answer it? We love that. You can go to any university in your local area, scroll through the faculty bios, see what their research interests are. If you looked under mine, you would see one of the things that I do is end of life and palliative in hospice palliative care. So you can immediately say, oh, that researcher is probably interested in my question. And the other thing I also say, and I hope that all of you will see yourselves as engaged in research in the future, is the most important thing you can bring is the idea and the question and the interest. Because we at the university don't always know where the gaps and needs are in the community. And if you can bring that forward to us, most of us are very, very happy to hear that and would be very interested to work with you. Or even if we can't work with you at that time, the next time some grant opportunity comes across my email, I already have your name and number, I can forward it to you. And so that was what happened with the convening grant that Donna and I got. It just randomly came, and I'm like, hey, maybe you're interested. And so I really encourage all of you to reach out and make those connections with the researchers and the academics in the university.
Thank you.
Yes, I am an elder care planner, an advocate, and a consultant. And the reason that I do this, and I'll get into it in more depth, is because of my personal experience as a caregiver to my mom and dad over a period of 15 years. My dad had a brain injury and my mom had Alzheimer's. And so one of my key passionate things is that people need to have education. They need to be aware of what to expect and early on. So when we're talking about end of life here today and hospice and things like that, I kind of have to, I'm a little bit outside of the box in that area because, I came from the financial planning background, and we talked about retirement planning, and the fabulous thing was, retiring at 55 and having this lifestyle of cruising and golf tournaments and, living the high life. And then the next thing you know, you're in hospice or it's end of life. But what about the 20 years in between, or even 30 years in between? Because you never know when something's going to happen to you. So anyway, that's why I'm showing you the beginning of one of the workshops that I do. It's called Boot Camp, or it's a presentation. I do 1 hour, or I do a series of 3-day workshops to get into more depth with people. Boot Camp for Living Later Life. And I had it was called For Later Life Care, and I thought, no, there's more to life than just care. It's about living later life with care. And so life's rules change, your needs change, and are you prepared? And I love the picture of this woman here living her dream and doing what she wants to do. And so let's see. Oh, there we go. Okay, so why we need planning. I say there's 3 key factors, and none of these are negotiable. They're all non-negotiable. We're all aging. My dad had an accident. It was non-negotiable. He had a brain injury. And then my mother was diagnosed with Alzheimer's. That was an illness, and that was non-negotiable. So one of those things is most likely going to get us. And so that's why I say it's so important to plan and to educate ourselves. And to educate ourselves at a very basic level. It doesn't have to be at the legal level or at the academic level. It's just really, and I talk simple, plain language. So, I'm not a gerontologist, I'm not a lawyer, I'm not a doctor, but, just a family caregiver and a daughter who was very passionate about what she saw, not just with her family, but with other people in facilities and in the hospital and all sorts of places. So why I actually became an elder care planner, advocate, navigator is because of what first started in the hospital with my dad. And I sort of temper this and I say healthcare and legal systems are not meant to be perfect. And there's no way that they can be perfect. And I had to say it that way so that I don't offend the legal system or I don't offend the healthcare workers. And so anyway, my father had this brain injury, and I won't get into how it happened and what happened, but there was a court case that ensued. And anyway, when he went into the hospital with the brain injury, the hospital said, well, he may live 2 years. He'll never be able to eat again except with a gastrointestinal tube, and he will never walk again. He was age 70, he had a brain injury, and they said, that's it, his life's over. And they said he wasn't a candidate for rehab. I know that my dad is a fighter, and I wasn't going to give up on him. He's not a candidate for rehab. Now, my parents, both of them, I'll say they were kind of delinquent parents because they didn't save money. They lived by the seat of their pants. They were divorced. They didn't have partners. So I did end up being their primary caregiver, supporter, and everything to them. At age 40, when my dad had his brain injury, he was age 70, we had not discussed later life planning. I think I'm going to need some water. Thank you. We had not discussed later life planning, and so it was a huge shock when all of a sudden I became the primary caregiver. Thank you very much. Thanks.
Collaboration.
That's great. That's great. So anyway, that's okay. You know, I was a financial planner. You know, years before I was a trader in the stock market. I had all sorts of gumption and strength and power to stand up for myself, but I had never ever experienced the healthcare industry or, you know, anything like that. I was just, you know, flying by the seat of my pants. Anyway, I went every day after the market closed, and I became the help Dad with the rehab. And the nurses were kind enough to give me a belt so I could pick Dad up safely and set him down. It took me about 6 months, and I had him walking again with a walker. So they said, that's a miracle. And I said, it's not a miracle. You know, I gave him some rehab. The reason they said he wasn't a candidate for rehab was because when you receive a knock on your head, it often affects your hearing. And he wore hearing aids. And they said it's not our responsibility to adjust his hearing aids. So they would have just let him go just because he couldn't hear. That would have been the end of his life. Just living in a wheelchair for 2 years and eating with a feeding tube. And so, speaking about the feeding tube, I had him eating salads and sandwiches. Within 2 weeks after he came out of his coma, he had a voracious appetite. And they said, well, you know, he could be at risk of aspirating. So, you know, he has to stay on a feeding tube. Well, I knew that my dad loved to eat. He told me, I'm hungry. So that's what we did. And he was in the hospital for a year in recovery. And they still had him on a feeding tube about 8 months later. He would pull it out and they would put it back in. We were falling through the cracks and I didn't even know it. I didn't know how to be an advocate. And so finally this nurse said to me, I complained to her like I'd complained to many, but she said to me, Barb, you are the voice, you have to speak up. And she said, the reason they're not taking the tube out is because they don't want to be responsible for him dying and choking and dying at the hospital. And I said, fine, it'll be our responsibility, take that tube out. And so they did. And, you know, it was funny, after he went into a care home, the first time I went in to see him, because I was busy working and stuff was happening, I went in to see him. And he said, Barb, they're still feeding me mush. Like, it's always like I'm eating these mushy green peas. I didn't realize that they still had him on pureed food. And so finally we got him off of the pureed food. But can you imagine if there had been nobody there to speak up for him? So anyway, I'm going to run out of time already. The actuary said Dad would live 7 years, and he actually lived 15 years. And so he received compensation for 7 years. And what I did is I hired a companion for him for 6 hours a week. So that was either 2 days for 3 hours or 3 days for 2 hours, whatever we could work out. That ended up being $10,000 a year. So Dad's money lasted for 7 years to pay for a companion. And then after the 7 years were up, guess who paid? I didn't want to give up his companion. I felt he deserved more than that. And so his lived experience was 15 years. And so here's a picture of my dad, his companion beside him. And in the care home, I had a wonderful care aide that is now a friend of mine. And she actually was my angel for 15 years and would help me out with Dad and tell me a few odd things that were going on. And so I say that care and support and having someone to speak up on your behalf, whether it's a family member or friend, representative, legally, whatever, will enhance your quality of life, because there will come a time when you may not be able to speak up for yourself. Not because you can't speak, but maybe you speak too softly or too slowly, or maybe you are having a little bit of dementia. And so in my work that I do, the areas of planning that I focus on, because my background is financial, it's easy for me to talk about that area, but I talk about the cost of care and medications, housing, and even family inheritance, and get people thinking about what exactly do they want to do with their money? This is really early stage preliminary stuff that then people can go to their notaries, or they can go to their lawyers, or go to NIDAS and then do their planning later. But what I do is early stage, simple language, planting the seed. And then talking about housing and socializing and lifestyles, and really talking about the realities of what goes on. Legal representation, it doesn't have to be your family. It can be a bank or a notary or a trustee or somebody, anybody. But it's good for people to know what their options are. And again, I just talk in generalities because I worry about my getting sued and all that, the legalities as well. I need to protect myself, and I'm not here to be the expert in those areas. Raising self-awareness, knowing when to ask for help, and accepting your limitations is really difficult for so many people. And that's where, egos get in the way, and the slippery slope of quality of care and stuff goes down. So understanding your limitations and raising the self-awareness, it empowers you. And then the personal care and personal needs is another topic. So my workshops are really empowering for people, and just plant the seed, and then I'm happy to refer them on to the other areas. And so I love this little picture because this is what happens often with people who think, I can do it myself, I don't need a housekeeper, I don't need to bring in meals or anything like that, and then it's a slippery slope. Well, I'm going to say this is the same thing for caregivers. Caregivers need to know when to ask for help, and they need to know what's ahead of them. And so again, I was one of those people who thought I could do it all myself. And then I tried also to get my brother, who is my only other sibling. He had completely different ideas than me. He thought, Mom and Dad are in a care home, let them go. Let the care home take care of them. I wasn't prepared to do that because I had seen what was happening with Dad already. And so know when to ask for help. Don't be a hero, and know your options. So I want to tell a little story about how I advocated for my dad and his care home. I loved his care home. I was the chair of the family council there for many years. I got along really well with the executive and all of these people. Oh, my tongue. Can I keep talking? Okay, forget I said that. Anyway, one of the issues, the biggest bully in my dad's care home was actually the union shop steward, and she was a care aide. And, I'm not saying anything bad about unions. This is just what happened to me. And, everybody knew about it. The staff knew, but she was a fabulous shop steward for the staff, but she was a psychological bully for the residents. And so, the only way I found out about it was that eventually my dad called me bawling like a baby. And I thought, you saw a picture of my dad, he's kind of a strong character. I thought, what's going on here? And when he told me what she was doing, I was shocked. And so how I resolved it was, I had several meetings with the director of care. And because nobody ever caught this woman, we couldn't prove anything. For 15 years, other staff members covered her shift so that she didn't have to go into my dad's room, so Dad didn't have to be alone with her and be subject to her bullying. And also, because it was a he said, she said kind of thing, she would be protected too if Dad was hurting her or something. But, I know that she wouldn't pull the covers up for him. He tried to use his cane to pull his covers up. She would take his cane away from him. So, of course, he's going to fight for his rights and try to get his cane. And then the other thing was throwing the clothes in his face when he was trying to dress or undress. These things would happen. But how do we prove that? My dad just told me that. And did he make it up? I don't think so. So, anyway, that's, I want to show you why it's so important to ask for care. So this is a family caregiver, time versus dollars. Okay, so this is my mother. My mother was completely different from my father. All my dad ever took was a multiple vitamin. after we got him off of this other anti-seizure drug that he didn't need. But my mom had borderline diabetic. She had Alzheimer's. She had, heart condition. She had cancer on her ear, and she had UTIs all the time. Denture issues, and some teeth, back and neck problems. All of these things require a GP appointment, first of all. Then the conditions are analyzed, and then you get to go to the specialist. So that's the first, second appointment. And then you get the follow-up appointment, and it's crazy. So for me alone, there were approximately 50 appointments a year that all had to be done during my working hours. And because as a financial planner, I was billing out at $100 an hour. It's all relative. If you make $20 an hour and you're spending 50 hours a year, or if you're making $50, it's all relative. It just so happened that we'll use these numbers for me. I was losing $14,000 a year in income, and I didn't mark down the travel time, the time it took me, but it took me like 90 minutes a day, a trip to there and back for my mom. The appointment time, I said half an hour, which always it's more than half an hour that you sit there, preparing to take my mom out, to settle her down. Maybe she wants to go to coffee or lunch, travel time, and that doesn't include the administrative duties, doing her banking for her and her billing and managing the care aid schedules. We had I worked with the Coastal Health for Mom. She sometimes had 21 different caregivers a week coming into her home. And because of her Alzheimer's, there was a little bit of schizophrenia there too. And sometimes she'd be calling the police department and not allowing the caregivers to come in. And so, there were lots of things going on. So anyway, I just wanted to show that you need to be aware of the costs of caregiving. If you're employed, if you're self-employed, if you're at home, maybe a housewife, and it's a little bit easier because your husband is supporting you. But I'm getting the time thing here. It is complicated, so you need to be aware of that. So how a professional advocate can help you is providing guidance and support to avoid potential problems with all of these things, deciphering the roles and responsibilities between professionals. Lots of times you're getting tossed around from person to person, you're not getting the real answer. Opening the line of communication between professionals, recognizing, preventing potential problems, solving problems with care and understanding, protecting your rights as an individual, understanding and respecting your personal values, and walking your journey with you. And sometimes I work on a monthly basis full-time with my clients, and I give them so much a month. Other time it's, ad hoc, by the hour for certain issues that are happening. So I say getting old is not for sissies. Plan to live by choice, not circumstance. And I've got a picture of Olga Kotelko here, who's a North Vancouver woman who has now passed away, but she was, a really wonderful world athlete. She was an Olympic athlete at her age, and she didn't start competing until she was in her 70s. But, it just goes to show that you can start doing this at any time of your life. And then the other picture is just a couple that, I put as another alternative. Maybe you're not an Olympic athlete, but, you can choose how you want to live. And I have so much more to say, but I'll stop now. Thank you very much.
Thank you so much, Barb. And I'd like to take this opportunity to thank all of our panelists and to thank the organizing committee and all of our guests.